Management of chronic limb-threatening ischemia, a comprehensive formal discussion for the Everything Surgery podcast. Welcome to the Everything Surgery podcast, where today, we delve into the complex and critical subject of chronic limb-threatening ischemia, previously known as critical limb ischemia. This severe form of peripheral artery disease represents the most advanced stage of arterial blockages in the limbs, resulting in chronic pain, tissue loss such as ulcers or gangrene, or both. Managing this condition demands a comprehensive, multidisciplinary approach with the ultimate goals of relieving pain, healing wounds, preventing major amputations, and improving both quality of life and survival. Diagnosis and staging. A systematic approach. Let us begin with the clinical presentation. Individuals with chronic limb-threatening ischemia often experience persistent, aching pain in the forefoot or toes. This discomfort is typically worsened when the leg is elevated, such as when lying in bed at night, and is alleviated by lowering the leg. These symptoms are indicative of severely reduced blood flow to the area. Tissue loss manifests as painful ulcers, commonly found on the toes, heels, or lateral aspect of the ankle. These ulcers are usually pale and do not granulate. In more severe cases, gangrene sets in, characterized by dry, black, mummified tissue. On physical examination, the affected limb often exhibits cool skin, loss of subcutaneous tissue, muscle wasting, thickened nails, and significantly diminished or absent pulses in the major arteries. A thorough vascular workup is essential. The ankle brachial index is a straightforward initial test, but its accuracy can be compromised in individuals with diabetes due to arterial calcification. Toe brachial index and measurements of toe pressures are more reliable in these cases. A toe pressure below 50 mm of mercury is especially diagnostic of severe ischemia. Transcutaneous oxygen pressure, which assesses skin oxygenation, can also be invaluable. Readings below 30 mm of mercury indicate poor healing potential. Non-invasive imaging modalities, such as duplex ultrasound, provide detailed anatomical and hemodynamic information. Computed tomography angiography is commonly used for procedural planning, offering a comprehensive view of the arteries from the aorta to the feet, including areas of calcification and potential targets for intervention. Magnetic resonance angiography serves as an alternative, particularly useful when contrast is needed or when avoiding radiation is preferred. Digital subtraction angiography, while once the gold standard, is now reserved for cases where an endovascular intervention is being planned. To further stratify risk and guide management, the Society for Vascular Surgery has developed the wound, ischemia, and foot infection classification system. This system considers the depth and severity of wounds. The degree of ischemia is measured by various indices, and the extent of infection. By integrating these components, clinicians can predict the risk of amputation and determine the urgency and aggressiveness of revascularization efforts too. The multidisciplinary limb salvage team. The management of chronic limb-threatening ischemia is not solely a vascular issue. Success is predicated on the involvement of a dedicated, multidisciplinary team. This team typically includes a vascular specialist who leads revascularization efforts, a podiatrist for foot care and offloading, a wound care specialist for advanced therapies, an infectious disease expert to direct antibiotic management, a diabetologist or endocrinologist to optimize blood sugar control, an orthotist or prosthetist to provide custom footwear and braces, and a physical therapist to support rehabilitation and mobility. 3. Management strategies. A tiered approach. The management strategy is tailored to each patient's overall health, the anatomical pattern of disease, and the clinical risk is determined by the wound, ischemia, and infection classification. 1. Best medical therapy and risk factor modification. Every patient, regardless of their treatment plan, should receive optimal medical therapy. This includes the use of antiplatelet medications such as aspirin or clopidogrel to decrease the risk of cardiovascular events. High-intensity statins are prescribed to manage cholesterol levels and stabilize arterial plaques. Smoking cessation is absolutely critical, as ongoing tobacco use greatly exacerbates disease progression. For individuals with diabetes, strict control of blood sugar is essential, aiming for glycated hemoglobin levels below 7 to 8% to reduce complications and infection risk. Blood pressure should also be carefully managed. In some cases, medications such as cilostazol or pentoxifylline may offer symptomatic relief, but they are not sufficient for patients with tissue loss. 2. Wound care and local management. Meticulous wound care is paramount. This involves regular removal of dead or infected tissue, known as debridement, and the use of specialized footwear or orthotic devices to relieve pressure on wounds. Infection control is achieved through culture-directed antibiotics, and in severe cases, surgical removal of infected bone may be necessary. Advanced wound dressings and therapies, such as negative pressure wound therapy and cellular or tissue-based products, may also be employed to promote healing. 3. Revascularization. The cornerstone of limb salvage. Restoring blood flow is often central to limb salvage. The choice between endovascular interventions, such as angioplasty and stenting, and open surgical bypass depends on the extent of arterial blockages, the patient's overall health, and the availability of suitable veins for grafting. Endovascular procedures are less invasive, carry lower immediate risks, and enable faster recovery, making them ideal for focal disease or for patients at higher surgical risk. However, they may not be as durable as open surgical bypass, which is preferred for long segment occlusions in suitable candidates. Sometimes, a hybrid approach that combines both techniques is used to address complex, multi-level disease. Research, including the bypass versus angioplasty and severe ischemia of the leg trials, suggests that for individuals with a life expectancy greater than 2 years and a suitable vein, bypass surgery may provide superior long-term outcomes. Nevertheless, for many others, an endovascular first approach is often favored for primary amputation. It is important to recognize that amputation is not necessarily a failure of care. It becomes the appropriate course when the limb is beyond salvage due to extensive and irreversible gangrene, when the patient is non-ambulatory with a fixed contracture, when the patient is too frail to undergo revascularization and the limb is the source of life-threatening infection, or when previous revascularization has failed and pain cannot be controlled. The objective is always to perform the least extensive amputation possible, maximizing future function and mobility. Conclusion. In summary, the management of chronic limb-threatening ischemia is a long-term undertaking that reaches far beyond any single procedure. Success is built upon a structured, multidisciplinary framework that integrates best medical therapy, attentive wound care, and timely, anatomically appropriate revascularization. The overarching goals are to relieve suffering, preserve limbs, and lower the significant risk of associated cardiovascular mortality. Thank you for joining us on this deep dive into the management of chronic limb-threatening ischemia. If you found this episode insightful, please like, share, and subscribe for more thoughtful surgical discussions here on the Everything Surgery podcast.